Welcome, folks. It's great to see people starting to join online. I'm just going to just give it another moment, just to let everyone in. Okay, I'm starting to see things slow down, but fantastic to have you all here. Good morning, good afternoon, depending on where you are. My name is Bianca Frogner. I'm a professor at University of Washington, and I direct the Center for Health Workforce Studies. I'm also part of the leadership team for the award network and the chair of the webinar committee. I'm so excited to have a fantastic set of presentations today on nursing home staffing, ongoing employer and state approaches. Again, this is part of our monthly webinar series, and you can find all of our future webinars at using the QR code below. Also, we welcome ideas from you all about future webinar ideas, as we want to make sure that we're meeting the needs of our award network members. So you'll find a link when you hit the QR code that gets you to a survey. I'm going to have Emily Franzosa, one of our webinar committee members, introduce our speakers, so we'll come back to that. Before we get started on today's webinar, I do want to just remind people that our next one is going to be on May 1st, and the topic will be on care models for aging veterans with dementia. And we'll have two presenters who work in the VA medical centers across the country. In case anyone is still interested, or if you were not already aware and thought you missed out on the opportunity, we've extended the deadline for the research fellowship program. Under this program, you can get up to $5,000 in direct cost to help support your work and or help you get connected with a research mentor. So certainly take advantage of this extended deadline, as it's only now a couple weeks away. So please spread the word in case anyone has missed it. Also, if you haven't already heard, save the date for July 2nd, where we'll have our second Award Network annual meeting in Baltimore, Maryland, following the Academy Health annual research meeting. I want to thank our webinar committee members, some of who are probably here today, but they play a really important role in organizing and setting up these webinars. So I really appreciate all their hard work today and all of our following webinars. And as always, you can find our prior webinars recorded online, and this one is also recorded online. And thank you to the leadership committee of the Award Network generally. We have Joanne Spetz as the PI of the program, and she's done an amazing job leading us to leading this program. Excuse me. And lastly, this webinar is supported by NIA, but the views expressed in the written material don't necessarily reflect the official policies of Department of Health and Human Services, or NIA. And I should probably say not just written, but also oral materials. So with that, I'm going to have Emily Franzosa pop on up, and she'll go ahead and take it away. Hi, Emily. Thank you.
Hi, great. Thank you, Bianca. And thanks to everybody for joining us today for this, I think, really exciting discussion about nursing home staffing and some of the roles that employers and states are playing in this important issue. I think all of our webinars focus on the dementia care workforce and building the dementia care workforce. And of course, we acknowledge that nursing home staffers are just such an important piece of that. So we're really delighted to hear from two groups today. First are representatives from the Moving Forward Coalition, which is a group that's focusing on advancing the goals that are outlined by the National Academies of Sciences, Engineering, and Medicine report that came out in April 2022, aimed at improving nursing home quality. And our speakers from Moving Forward are going to include Jasmine Travers, who's an assistant professor of nursing at NYU Rory Myers College of Nursing and an adult gerontological nurse practitioner. And Dr. Travis has really focused her work on designing and conducting research to improve health outcomes and reduce health disparities in older adults using long-term services and supports, and was on the NASEM committee that developed this report. So we're really excited to have her here. She's also joined by Betsy White, who's an assistant professor of health services policy and practice at the Brown University School of Public Health. And Dr. White's research focuses on understanding how frail, medically complex older adults receive healthcare and how factors affecting the nursing home and primary care workforces impact quality outcomes in long-term care. And finally, we'll hear from Kezia Scales, who's the Vice President of Research and Evaluation for PHI, which is an organization committed to promoting quality direct care jobs as the foundation of quality care. And I should mention that Dr. Scales is also, as you just saw her picture, part of the Award Network leadership team. And secondly, we have two speakers from ABT Global who are going to speak to a CMS commissioned study that they conducted recently to explore the level and type of staffing that's needed to ensure nursing home resident safety, and also the feasibility of increasing nursing home staffing. And this study is a really enormous and ambitious undertaking that we thought would be really interesting and valuable to this group, both from a research practice, it's a really interesting model and design, and from a practice perspective in thinking about how we continue to build this workforce. And our speakers from APT are Alan White, who's a principal associate with a PhD in economics, who has 28 years of experience conducting research on nursing home staffing and quality of care, as well as Matt Knowles, who's a health economics senior analyst at APT, who also works on issues of the economics of healthcare access. So I think, these five speakers really just bring a tremendous wealth of knowledge about these issues, and I'm delighted to be able to hear from them. We're going to let them take it from here, but we'll reserve about 10 minutes at the end for questions and comments. So if you do have any questions as we move through the presentations, please feel free to stick them in the Q&A and we'll address them at the end of the session. But for now, I will turn it over to Dr. Travers.
Great. Thank you so much for that introduction, Emily. And thank you so much for this invitation. We are excited to be here just to share some of our work through the Moving Forward Coalition focused on certified nursing assistant retention efforts, specifically related to supporting advancement through registered apprenticeships. I'll just go ahead and go to the next slide. And just to note, we are presenting on the behalf of our Moving Forward Workforce Committee and the coalition at large. So I'd be remiss to jump into our Moving Forward work without first sharing how the coalition came about. Many of you are familiar with the NASEM 2022 Nursing Home Report, which examines how our nation delivers, regulates, finances, and measures the quality of nursing home care. And it delineated a framework and general principles for improving the quality of care in nursing homes. Like what was shared previously by Emily, I was a member of the committee that worked on this report. And when developing recommendations that would improve the quality of care in nursing homes, our main funder, which was John A. Hartford Foundation, charged us with focusing on recommendations that would be bold and actionable, along with recommendations that were not going to sit on a shelf, but be moved into action. Next slide, please. Thus, that's where the Moving Forward Nursing Home Quality Coalition comes in. Moving forward, I love that. And just thinking about that, moving into action. The coalition's goal is to drive specific practical and actionable improvements in nursing home quality while building a sustainable collaborative to continue moving this important work from the NASEM report forward. So who we are a group of individuals and organizations that have come together to drive specific actionable improvements in nursing home quality while building a sustainable network to continue this vital work. And in the first 2 years, which we are coming up right now, our purpose was to develop, test, and promote action plans to improve nursing home resident quality of life. Our vision is that every nursing home will be a community in which lives are nurtured, residents are empowered, and where people want to work. I was at a GSA session last year or 2 years ago, and one of the presenters asked the audience, what would be a headline that you wanted to see specific to nursing homes in the next 5 years? And an audience member responded and said, nursing homes, the best place to work. So just thinking about where people want to work and thinking about what makes these places that we have identified as the best places to work, the best place to work. And then just going over to our mission. Our mission is that we will make vital changes in policy and practice through the power of bringing diverse voices together now. So how the coalition is set up. It consists of 7 committees that reflect the 7 goals of the NASEM report, in which goal 2 is focused on ensuring a well-prepared, empowered, and appropriately compensated workforce. It's the goal that our committee is focused on, which is Committee 2, staffing a well-trained workforce. Our committee consists of 20 individuals reflecting diverse fields, industry, academia, labor unions, policy, nursing homes, and many other individuals. And specifically related to goal 2 of the NASEM report, we chose to focus on 2 recommendations. The first is recommendation 2A, which is on ensuring competitive wages and benefits. And then the second is focused on recommendation 2E, which is advancing the role of and empowering CNAs. Now I want to take a little bit of time to just share how we chose to focus on these recommendations, because if it were up to our group, which Kizzy and Betsy know, we would have tried to address all nine recommendations. Next slide. Thank you. So one reason is because of the significant need to address retention among CNAs in nursing homes, in which the second bullet that you see here is that CNAs typically face limited opportunities for advancement and often feel that they are underprepared and underappreciated, which yields to staff shortages, turnover, job dissatisfaction, and burnout. And then next slide, please. And second, in a survey administered by NACA, which is a CNA association that advocates for policies and practices that advance certified nursing assistants, they asked CNAs, if you were to leave or have thought about leaving the CNA profession altogether, what would it take for an employer to hire you back? What we see here is the top response, with almost 90% of people saying that it would take wages and benefits to hire them back. And not too far behind, if we just look at the 4th line, is better training and opportunities for career advancement. So with that, I will pass it off to Betsy, who will share more about our committee's approach to addressing these issues specific to these 2 recommendations.
Thanks, Jasmine. Yeah, so we as a coalition have really honed in on this focus around how do we create better career opportunities for CNAs to advance within their profession. So one of the kind of initial things that we did was just the general scoping to understand what kinds of career pathway models are out there currently. And the general takeaway is that there's lots and lots of pilots and small scale models, but very few sustainable, replicable models. Generally these types of models tend to focus on similar content areas: dementia, behavioral health, end of life care, leadership, peer mentorship. They typically come with a wage progression and possibly a change in job title. And by and large, they're generally very well received among those who are directly involved. People really like these types of models, but lots of differences as well, all different kinds of tiers and credentials that people can receive, and that affects portability for an individual CNA. If they go through a pathway model at one employer and then they want to pick up and go somewhere else, they can't necessarily reap the benefit of that training that they received. Some models are done as a registered apprenticeship, some are not. I'll say a little bit more about that in a minute. All sorts of different funding sources. These are definitely things that are very dependent on grants, which are time and scope limited. And then there's some models that serve as career lattices, so they allow CNAs to advance within the CNA role. And then there are other models that support CNAs through a career ladder to advance to a different role, either as an LPN or a med tech or some other a different role. just to say a little bit more about this, these are kind of like the four buckets of pathway models that are out there. So at the top here, there are models that support trainees that are moving towards CNA certification, and they provide kind of additional wraparound services and mentorship to make sure that the CNA is successful. Out in California, there are two pretty large programs that work in conjunction with the state workforce development boards to provide some of the needed wraparound services to trainees. SEIU also has registered apprenticeships that they do in several states. This is probably the most replicable model that's out there. That's under their training and employment funds, where they provide wraparound services, mentorships as CNAs are going through the initial training. Then at the bottom, there are a whole bunch of different types of models that support that are career pathways for people who are already CNAs and looking to advance within that role. There are some that are done as sort of like micro-credentials or badges. There's a couple of examples. PHI has a number of models and lots of other examples out there. The area that we focus on specifically is this category down in the bottom right, which are pathway models that support CNA advancement as a registered apprenticeship. So why have we sort of honed in on registered apprenticeship? So registered apprenticeship is a nationally recognized portable credential that comes with an accompanying wage progression. And it's an earn and learn model. So CNA is going through the apprenticeship as they're being paid, and they're receiving that additional mentorship. Registered apprenticeship programs have to be registered either at the state level or at the federal level, which means that there are core standards that they have to meet. When you have standards, you can replicate them elsewhere. When you can replicate something, you can evaluate it and build the evidence base to further support replication. And then also there's a lot of apprenticeship specific resources right now, both at the state and federal level in terms of funding and sort of administrative technical support that are out there. So there's registered apprenticeship just brings the potential for a lot of added structure around CNA career pathway models. So how does this all translate into our work on the coalition? So this is something that has evolved somewhat naturally over time. Initially, we were actually planning for a one-state pilot model of an apprenticeship program. For a number of reasons that didn't really pan out, but we still have been quite busy. So I'm going to talk through each of these pieces just a little bit more. Probably the biggest product that has come out of the Moving Forward Coalition's work involves the Geriatric Workforce Enhancement Program. So if you're not familiar with these, the GWEPs, as they're called, are funded under HRSA to support workforce training for community-based organizations that care for older adults, including nursing homes. So there are currently, the GWEPs are located all across the country. There's currently 48 GWEPs across 35 states and 2 territories. And so the Joan Weiss, who's the director of the GWEP program at HRSA, sits on our committee. And as we were doing our initial scoping review and just talking to a lot of different programs and models that are out there and kind of gathering this information, Joan took this back to her team at HRSA, and they made the decision that with the next 5-year funding cycle of the GWEPs, which starts this summer, that the GWEPs would be responsible for developing registered apprenticeships to support an advanced role for CNAs. So this is a really potentially exciting opportunity because, as I mentioned initially, the current landscape is that there's just so much fragmentation and variability. And the GWEPs already have this infrastructure through the GWEP Coordinating Center, which is funded through Hartford and sits in AGS, to support shared learning among the GWEPs. They used this coordinating center previously to stand up age-friendly health systems. And now with the next phase of the coalition, we're talking about how do we work through that coordinating center to help assist the GWEPs as they're standing up these registered apprenticeship models to support standardization across the GWEPs and support shared learning to get these types of pathway models to a larger, more sustainable model. Another key piece that we've been doing, because quickly when you're starting to think about CNA workforce development, you find yourselves quickly in the weeds of local and state policy and practice environments. So we've just been doing a lot of networking and education with different partners across multiple states. These are some of the states where we've been a little bit more active, where there's actually kind of formal task force that, we've given presentations to, or just a lot of, introductions, networking. The other thing that you'll find is that there's a lot of people and organizations that work in this space, but they don't necessarily know what each other is doing or work well with each other. So we've just been doing a lot of networking and connecting of different entities. Another key partner that we've been collaborating with is the Council of State Governments. So I would say one of the real strengths of the Moving Forward Coalition is the breadth of organizations and individuals and perspectives that we have on the coalition. But one area where we don't really have a deep bench is in state government expertise. So that's where the Council of State Governments, CSG, comes in. They actually receive funding through the Commonwealth Fund to build out this national long-term care workforce network. They have regular webinars. They've developed this policy guide, and they actually do in-person and virtual technical assistance to state government officials. So we've presented to them a lot, multiple times, have been doing a lot of networking, and they've been a real key partner to kind of add to that bench of expertise around state government. So the final piece I'm actually going to hand over to Kezia now has been around the Illinois Medicaid Incentive Payment Program, and Kezia has been chairing that piece. So I'm going to, Kezia, hand off to you there.
Great. Thank you, Betsy and Jasmine and Emily, for convening us, and thank you all for attending. So in addition to all of the work that has been moving forward through the Moving Forward Workforce Committee, a sort of parallel piece of work for the committee has been looking at how do you finance wage enhancements for CNA. So, we need to build out career pathway opportunities, but we need to make sure that we have a system that actually incentivizes individuals to explore those career pathways and employers to support them and be able to pay them an enhanced wage accordingly. And so we have done work to understand better the range of incentive payment programs through Medicaid for nursing homes that have been tried out across states, and the different structures of those, the different metrics that they focus on, and to what extent have workforce focused metrics been included in those Medicaid incentive payment programs. Often, there's a range of titles or terms like value-based payment and payment for performance, et cetera. And there are a number of states that have these types of incentive payment programs in place through their Medicaid nursing home funding that include something to do with the workforce retention metrics or job satisfaction metrics and other things. The one that we have been particularly learning about and monitoring is Illinois' new nursing home transformation program, which includes several different incentive payment streams for nursing homes that are designed to support recruitment and retention of this workforce. And one that is particularly exciting is an enhanced payment based on promotion for CNAs. So it's fairly agnostic about what that promotion looks like. It's not to a particular role, but it's more about encouraging employers to develop and test advanced roles, advancement opportunities for CNAs. And if they do so, they are eligible to receive an enhanced payment that they can invest in the wages for those promoted CNAs. So it's just a way of kind of tying together our work around CNA career pathway models and the potential of registered apprenticeships as the way forward there, to what are the financing structures that might support implementation and sustainability of those approaches. So in the last few minutes that we have, I'm actually going to sort of switch hats and speak as in my role as VP of Research and Evaluation for PHI to just tell you I'm going to speak on 1.5 speed here, because I just want to really quickly introduce you to a study that we conducted on the use of contract CNA staffing in nursing homes as another piece of the puzzle that we're looking at here around how we are addressing the recruitment and retention crisis in nursing homes and how we can and should aim to address it going forward. So what I'm going to say in the next few minutes is based on a report that we just released earlier this year. It's available. This study was conducted in collaboration with the UCSF Health Workforce Research Center on Long-Term Care. And so the report is hosted on the website. And there's a link here to access the report, and I'm also happy to share it afterwards. Next slide, please. This work was supported by HRSA, but of course the contents are those of the authors and not necessarily representing the official views of HRSA or the US government. Next slide, please. So what we know is that there are widespread CNA recruitment and retention challenges in nursing homes, and to some extent those challenges are driving necessarily temporary solutions. We know already that nursing homes use 24% more contract staff, so temporary staff, in 2020 at the onset of the pandemic versus 2019. And by 2022, up to half of all nursing homes were relying on some amount of contract CNA staffing. But the existing evidence indicates that adding contract CNA staffing to fill staffing gaps does not improve care outcomes the way that adding fully employed CNAs do. And so there are significant concerns in the field about the impact of using contract staff on continuity of care, the training and competency of the workforce, and of course the rising costs associated with this reliance. So next slide, please. So we set out to learn a little bit more about this trend, to look at how have contract CNA staffing patterns varied in relation to nursing home occupancy from prior to the pandemic, 2017, all the way through 2022, and how did that trend vary according to nursing home characteristics, and to learn a little bit more about the relationship between those contract CNA staffing trends and care quality outcomes for nursing home residents. The next slide, please. We brought together a whole, an array of data sets to try to answer these questions, and we conducted descriptive and regression analyses. I'm just going to zoom on through to the next slide. So the first thing that we found was confirmation that contract CNA staffing has increased over the past 5 years, both in terms of the percentage of total hours that are filled by contract CNAs, and you can see that in the first figure. Back in 2017, it was only 2% of all CNA hours. By 2022, it was 11%. There's also been a dramatic increase in the number of, or the percentage of facilities that are using any amount of contract CNAs from 22% back in 2017 up to over half, 56% by 2022. And then this slide shows the same trend in a slightly different way. What you can see here is that middle line is median resident census, the blue line, and that's sort of decreased with the onset of the pandemic and going forward, in line with employment levels for regularly employed CNAs and all CNA, total CNA staffing. But that bottom line, the light orange line, shows that contract CNA hours in the same time period increased. So even as the workforce contracted along with the nursing home census, the number of contract CNA hours was actually growing. And then when we looked at hours per resident day provided by contract CNAs, we saw a clear upward trend as well, but with some variation by nursing home type. So in the first figure there, you can see that contract CNA hours per resident day were sort of slowly but surely climbing all the way from 2017. And then there was a pretty dramatic uptick in late 2020. And that continued to climb. So we started out at 3% hours per resident day provided by contract CNAs. We ended up with about 18% by 2022. The notable difference was that while most facilities sort of then leveled off and converged, nonprofit, non-chain nursing homes actually continued to increase. That's the blue line, and you can see that continued to increase by the end of 2022. The second figure shows restricts the sample to just those nursing homes that used any contract CNAs, and you can see a similar trend just with higher starting and ending points. So on the next slide, so what we found in terms of the the association with quality outcomes for nursing home residents is that, yes, higher levels of contract CNA staffing are significantly associated with lower quality measures when looking at the 5-star overall care quality measure. And that holds true when controlling for a range of facility and local, state level and local factors. When we looked at the specific quality measures, we saw mixed results. So we did see significant associations with higher rates of catheters inserted and left in, UTIs and pressure ulcers for long stay residents. And for short stay residents, we saw a negative association with improvements in function. But we didn't find significant association with between contract CNA staffing usage and depressive symptoms or the rate of receiving new antipsychotic medications. Okay, and so I promise I'm finishing up here. Just basically, in short, what we found was that use of contract CNA staffing in nursing homes was already increasing pre-pandemic, but really increased dramatically in late 2020 to 2021, and then appears to have leveled off, but at a historic height by the end of 2022. We did see some variation with nonprofit, non-chain nursing homes, probably paradoxically because those nursing homes, in taking the more high road employment approach of higher staffing, had to rely on contract CNA staff more in the context of greater competition for these workers. And the bottom line here is that as contract staffing agencies gain a foothold, as they become increasingly part of the picture here, nursing homes will increasingly compete with workers for with these staffing agencies for their workers, or as we're seeing, actually create their own staffing agencies, which really further complicates the picture. And all of that has ongoing implications for CNA staffing levels, job quality, of course, and care quality as well. The final slide just has some thoughts about further research on this, but I'm going to skip over this to make sure that we have enough time to pass over to our next speakers. Thank you.
Wonderful. Thanks to all of you. So much food for thought in all of those presentations. So next I'm going to turn it over to our colleagues from APT. Alan, do you want to start off?
Hi, yeah, this is Alan. I'll start off. And that was a really good presentation. I was just enjoying it, and now I have to transition and present. I'm going to try to do that, but I think what I'm going to present will flow really well with the previous presentation. I'm going to share some slides, all right? We'll talk about the nursing home staffing study. And it's a study that we completed in 2023. Give a little background on the study. So in February of 2022, the Biden administration announced a set of nursing home initiatives that were intended to improve the safety and quality of nursing home care. And amongst those initiatives was establishing minimum nurse staffing requirements with the goal of ensuring that all nursing home residents are provided safe, quality care and that workers have the support they need to provide high quality care. An ambitious timeline for developing a proposal for minimum staffing requirements. So CMS reached out to APT to support them. We basically conducted a mixed methods nursing home staffing study to help guide CMS with developing or looking at options for minimum staffing requirements. I think they reached out to APT because we've been doing this kind of work for them for a long time. I worked with CMS on the kind of the EPIC nursing home staffing study that they completed between 1998 and 2003, and we actually built on some of the elements in that study for this current study to try to drill down and look at the issues that need to be looked at to develop a staffing requirement. So there's a lot of literature out there. I think it's pretty well established that nursing home staffing levels have been identified as a critical factor in determining the quality of care in nursing homes. And I think probably to everybody here, it's probably obvious that there's a relationship between staffing and quality, at least at some point. But for developing minimum staffing requirements and specific policies, it's not enough to say there's a relationship between higher staffing and better quality. We really need to kind of drill down and understand more specifics about that relationship, specifically around what the cost and benefits are at different staffing levels between improvements in quality. So there's a lot of literature out there that shows a relationship between higher staffing and better quality. probably the best study out there that looks at kind of specific thresholds or relationships. This was the CMS staffing study that was completed in 2001. There's a lot of incorrect information about that study on the internet if people look it up. Two common misconceptions are, one, that it recommended a specific minimum staffing level of 4.08 total nursing hours per resident day. A second misconception is that it identified 4.08 as a specific staffing level that was needed to provide adequate quality care. Neither of those statements is actually true based on what's in the report. What that staffing study did find, however, was some specific staffing thresholds above which no further improvements in quality of care were observed. And those were between 0.55 and 0.75 for RNs, depending on whether we're using short stay or long stay measures, between 1.15 and 1.3 for licensed staff, RN plus LPN, and between 2.4 and 2.8 hours per resident day for nurse aides. So that's some of the background. This is just a high level description of the different components of the staffing study. Had some formative activities to develop our design, including a literature review and some stakeholder listening sessions, and then a set of qualitative activities that included site visits and stakeholder listening sessions. Several different quantitative analyses. One set looked at the relationship between staffing and measures of quality and safety. Second, used simulation analysis to look at how rates of delayed and omitted clinical care varied with different levels of licensed staff. And that one actually was intended to mesh up with work we did in the 2001 staffing study, which did the same thing, but for nurse aides. Looked at analysis of state staffing requirements. Matt's going to do a deeper dive into those analyses in just a few minutes, and also did some analysis to look at the cost and savings associated with increased nursing home staffing. So based on all those components, looked at quality and safety implications of staffing requirements, looked at issues around feasibility and cost, and developed some options for CMS to consider. I don't have many charts in here because we're trying to keep it at a high level. We don't have too much time, but this is a chart that shows the distribution of total nursing hours per resident day across all nursing homes in the country. Just want to highlight, there's a lot of variation in staffing levels across nursing homes. The median is about 3.6 hours per resident day. 10% of nursing homes have 4.91 hours or higher. 10% have 2.79 hours or less. So there's a lot of variation. A lot of what we're trying to do in the staffing study, at least the quantitative analysis, is understand how this variation in staffing that we see across nursing homes in the United States relates to measures of quality and patient safety, and what that might imply for potential minimum staffing requirements. I'm going to give you an overview of our key findings. Start with the qualitative findings. Well, first, kind of across the whole study, there's kind of a general finding that there's definite potential quality and safety benefits associated with increased nursing home staffing on the qualitative side. General agreement that quality of life, quality of care, and safety are adversely affected when nursing homes are short-staffed. Many of our staff that we talked to reported their current workload was not reasonable to provide quality and safe care. Most respondents believe that a minimum requirement would decrease staff burnout, improve person-centered care, and decrease safety concerns. But there are also concerns about the feasibility, just some of the hiring and retention challenges. I think it kind of links to the previous presentation and just the increase that we see in use of contract nurse aid staff, some of the hiring challenges that are out there. On the quantitative side, we found pretty consistently that nursing homes with higher staffing levels tended to have better performance, regardless of the measure that we used. Found the strongest relationship between quality and staffing for RN, an inconsistent relationship with LPNs. RNs were really the strongest driver across the board. Found a relationship between a higher share of Medicaid residents at nursing homes and lower staffing. Unlike the 2001 staffing study, we did not find any evidence of any threshold beyond which we didn't see further improvements in quality associated with higher staffing. Basically, just throughout the whole distribution, higher staffing was associated with better quality. We also found that there'd be some savings from a minimum staffing requirement in terms of reduced hospitalizations and emergency department visits, so produce some savings for the Medicare program. Not nearly enough to offset the costs, but some savings. Last chart I have here. This is a chart that shows the relationship between staffing decile and quality, basically using the quality score that we use in the 5-star rating system. I'm going to focus on the lower bar there, the purple bar. Nursing homes below the 3rd decile in terms of total nursing hours per resident day, 39% of them met a standard of acceptable quality that was based on the 50th percentile. So 39% of nursing homes that are in this lowest staffed group had above average quality. You can see that chart, the slope goes upward on that chart. When you get up to the top decile, we're up over 70% of the nursing homes in the top decile are above the 50th percentile in terms of quality. So you definitely see a relationship between higher staffing and better quality. There's still high staffed nursing homes that have low quality care and vice versa, but definitely a relationship there. I'm summarizing lots of work really quick, but based on these analyses, we came up with several different options for CMS to consider in terms of minimum staffing requirements. Low, medium, higher, and highest. They vary with respect to the level of RN staff that they require and the level of nurse aide staff that they require. Obviously, with a higher requirement, there's a higher percentage of nursing homes that need to add staff, 82% for the highest option we looked at, which was 0.7 RN hours per resident day and 2.45 nurse aides. The costs go up with a higher staffing requirement, $2.2 billion for our low option, up to $6 billion per year for our high option. What do you get for that additional cost? You get improvements in quality. You get more nursing homes that are above the standards that we looked at in the study. You just get nursing homes increase their staffing, they do better. That's what the analyses show. So for policymakers, it's around balancing these costs and benefits along with some of the feasibility concerns. All right. So I zipped through it really fast, but study findings provide CMS some options for setting minimum staffing requirements, showing the trade-offs between these policy options. I think the study findings confirm the important relationship between higher staffing and better quality. In terms of policy, got to balance cost and feasibility with the implications for quality and safety. And there were some findings from the qualitative component of the study that identified some feasibility concerns. We did not attempt to do a workforce study here, so we did not address whether the nursing workforce is adequate to support different minimum staffing requirements, and definitely recognize that the additional staffing costs, as we showed, would be in the billions, could be a barrier to implementation of minimum staffing requirements. That's all I got, Matt. I'm going to turn it over to you. Matt's going to talk more about some analysis we did looking at the impact of state minimum staffing requirements.
Thanks, Alan. Do you mind taking away your slides?
Yeah, sorry.
No worries. Can you see this, Alan?
Looks good, Matt.
Yeah.
Okay, great, thanks. Okay, so I'm going to be presenting on another section of the nursing home staffing study that Apt Global did for CMS. And this section is called The Impact of the 2020 Massachusetts Nursing Home Staffing Requirement. And the purpose of this section of the report was really to look at whether we can use the state staffing requirements that have been passed for a long time now as a model for what could happen with a similarly structured federal requirement. So as Alan showed in the previous sections of the presentation, there is a definite relationship between staffing levels and quality, but any kind of requirement that is implemented on the federal level isn't going to be the federal government manually setting staffing levels. It's going to be implementing some sort of requirement that has some kind of penalties related to not meeting that requirement for nursing homes. So the effectiveness of that kind of requirement is going to be predicated on how nursing homes respond to the incentives at play. And so in order to get a better idea of how nursing homes would respond to such a federal requirement, we can look towards similar requirements that have been implemented in the past at the state level as sort of like pilot programs in that regard. So there's been a lot of empirical literature on the effectiveness of these state programs in the past, and generally they show that these state requirements, when properly specified, do have positive impact on staffing levels and often quality. However, the gap that we're seeking to fill with this project here is that there haven't been any studies published using post-COVID-19 public health emergency data. And the reason why this is an important gap to fill is that it's well known that nursing homes have had staffing challenges in the post-COVID-19 PHE era, and these staffing challenges could very well hinder the relationship between staffing requirements and staffing levels and therefore quality. It doesn't matter if you have a high requirement if nursing homes can't find the staff in order to meet it. So our research question was, can state nursing home staffing requirements increase staffing levels and or quality in the post-COVID-19 PHE era? So we did a review of the legal landscape to see which states had changed their staffing requirement policies since the beginning of the COVID-19 PHE, and we identified 6 separate states. Now, unfortunately, of these 6 states, we were only able to identify one state, Massachusetts, that had a policy that we thought could actually result in detectable increases in staffing levels. So the reason for that being that a lot of these other states had caveats in their policies, like allowing for non-nurse staff to count towards the staffing requirement, like in Arkansas, or they had a total HBRD requirement increase that wasn't actually very substantive, like in Connecticut, or that was quite low. So most nursing homes, if not all nursing homes, already met it, also like in Connecticut, or frequently total HBRD was not part of the requirement, and the requirement was only for something like nurse aides, like in New Jersey. So we focused on Massachusetts, and this policy was enacted in October of 2020 and became effective at the very beginning of 2021. The total HBRD requirement for nursing homes increased as a result of policy from 0.24 hours per resident day to 3.58 hours per resident day, which is not only a very large increase from effectively 0 to 3.58. 3.58 is actually a number that where a lot of nursing homes would fall below. So it's a very salient increase. There was an RN requirement. However, the penalty for noncompliance only enforces the total HBRD requirement, and this penalty was a % reduction in state Medicaid payments received for Medicaid patients cared for. So because we're only looking at a single state, if we're trying to estimate the impact of this new policy, instead of doing something like differences and differences, we elected to go with the synthetic control method. And this is a good alternative to differences and differences when there's only a single unit or state, in this case, treated in your sample. So for those unfamiliar with synthetic control, what this does is it creates a synthetic comparison unit to your treated unit, so Massachusetts in this case, from an optimally weighted average of the units in what's called the donor pool, or in this case, states. So we're looking at outcomes in Massachusetts, like staffing levels. What we're able to do is optimally sort of piece together the outcome trends from all other states in the United States into something that kind of matches Massachusetts outcome trends prior to this new policy implementation. And the assumption here is that when you do this and you create sort of a synthetic comparison unit that matches Massachusetts pre-intervention trends, then that new synthetic comparison unit is going to provide a valid sort of counterfactual for what would have happened to, say, staffing levels in Massachusetts had there not been this new staffing requirement implemented. Now, here are the main results. These are synthetic control estimates for Massachusetts on total nursing staff hours per resident day between 2015 Q3 and 2022 Q2. So because of the way that the Massachusetts policy is structured, which is targeting facilities that have less than 3.58 hours per resident day nursing staff, and specifically it's going to be more salient for nursing homes that have higher shares of their average daily census being comprised of Medicaid patients, we focus on a subset of facilities that had below 3.58 HPRD staffing in the quarter before the policy changed, and of those nursing homes, those that were in the 75th percentile of Medicaid patient share or above. So we plot the results of the synthetic control analysis for this subset of nursing homes in Massachusetts in panel A. Here, the purple line shows the average hours per resident day across Massachusetts nursing homes that meet this sort of requirement of high Medicaid share, low staffing. And the dashed gray line plots the mean hours per resident day of the synthetic comparison unit that's generated using the synthetic control method. So as we can see, the synthetic, oh, sorry, one more thing. And the vertical red line demarcates the enactment date of this new staffing policy, and the vertical green line demarcates the effective date. So as we can see, prior to the enactment date, the synthetic control method appears to be working well. The two pre-intervention trends are following one another, but then after the vertical red line, we see a diversion between the Massachusetts and synthetic Massachusetts trends, indicating that Massachusetts nursing homes appear to have higher staffing levels afterwards than the comparison unit. And if we estimate the magnitude of this effect by subtracting the pre-intervention difference from the post-intervention vertical difference between these two lines, we get a treatment effect of 0.246 hours per resident day. And we're also able to conduct statistical inference by comparing this effect estimated for Massachusetts to what sort of a fake effect would be for all other states that didn't actually receive the policy intervention. And we find that this appears to be, according to our criteria, statistically significant at the 0.05 level. So like we said, the reason why we looked at this high Medicaid share and low staffing population is because, by the way that the requirement is structured, this is where we would expect to see the largest effect. So the sort of converse of that is we wouldn't expect to see a large effect in other subsets of nursing homes, like low Medicaid share, low staffing in panel B, high Medicaid share, high staffing, low Medicaid share, high staffing in panel C and D. And in fact, that is exactly what we see, is we don't see a comparable effect in those sets of nursing homes, which increases our confidence that we're seeing a true effect here in panel A. We're also interested in seeing what nursing staff types are driving this effect. So in panel A, we see total nursing staff like before, but we also look at RN staff, LPN staff, and nurse aide staff. And when you look at these trends in Massachusetts staffing compared to the synthetic Massachusetts staffing, it really appears as though nurse aide staff is what's driving things. You see a very large increase here compared to the synthetic Massachusetts as compared to RNs and LPNs. We, of course, look at quality measures as well. And we aren't able to detect any statistically significant effects on total quality measure score here, nor are we able to detect any significant effect on the 5-star safety score. And again, these are for Massachusetts nursing homes that are high Medicaid share and low staffing prior to the regulation changing. So, we believe that nursing home responses to state staffing requirements provide a model for what might happen under a similar federal requirement. We found that a requirement with a high HPRD threshold and a non-trivial penalty for compliance, like what we see in Massachusetts, can increase staffing levels in the post-COVID-19 PHE world. This is what our results indicate. However, we also don't find any significant effect on quality or safety, but this is actually consistent with previous literature, which finds that staffing requirements that induce an increase primarily in nurse aides actually haven't been associated meaningfully with increases in quality and safety. So this is actually nothing new in the literature. So it's nice to see that it's reflected here as well. All right, and that's everything. Thank you very much for your attention.
Great. Thank you so much, Matt. That was, and Alan, that was really wonderful. I know we stuffed so much content into this session that we only have a very few moments for questions. But I think we've just heard such important things from our panelists today about, both, what do we do about this workforce crisis and how do we know if what we are doing is working? So we do have one question, Matt. I think this is for you on what's going on in panel C and D. It appears there may be some anticipatory increase prior to the policy implementation.
So panel C and D
I think that was
just
one
in
of
general.
your earlier slides.
Right. So yes, there's a huge spike that occurs in a lot of these subsets of nursing homes, but just in general, sort of right before, in Massachusetts at least. But actually, this is mimicked in a lot of different states, right before the date in which the policy begins. So since the policy begins in October of 2020, so this is like right in the heat of the COVID-19 pandemic, like soon after it started. Hours per resident day is, of course, calculated by sort of dividing the total number of nurse staff hours by the total number of residents. And if we remember, there was sort of a huge exodus of people from nursing homes around this time. So this is really due to the fact that the denominator in that number is changing really substantially, and you can see it in the data. So yeah, it does sort of look like anticipatory when you take it somewhat out of context. I could see how it could be interpreted like that, but I really think that it's due to the sort of macro trends that are going on at the same time of the resident census levels in nursing homes.
Okay, wonderful. And I see we have another question about whether this great study has been published. The answer is yes, and we will add links to both that study and the NASEM report in here. And I see Richard also brings up that an important point not discussed is nursing homes have been required to provide sufficient staffing to meet the needs of their residents for several decades. And I know we're right at 1 o'clock, so if anybody has to drop off, please do. But for those who can stay on, I think we can take a minute or two to address this question. So the question is, how does focusing on the admittedly low state requirements fulfill the president's promise to ensure that every resident receives the care and services to which they're entitled? If anybody wants to take that very, very easy and quick to answer question in our last minutes.
It seems like we may not have any takers, but it certainly sounds like it's a good thing to mull on. And, I know we're at time. And so I do hope that maybe this helps to continue the conversation further. As you said, Emily, there's so much food for thought here. Any closing thoughts from you before we sign off? Emily?
No, I think that's it. Thank you all. Thanks to all of our panelists for this really important and thought-provoking work. And we look forward to continuing this conversation with all of you.
Thank you so much to everybody. And this will be recorded and available online soon. Take care. Have a great day, everybody.
Thank you all.